Good morning, everyone. My name's Emily Jenkins, and I am with the John P. Mayhew Foundation, and I am so pleased to have the honor of introducing the recipient of our 2020 Health Defender Award. She represents Illinois' 4th Congressional District and currently serves on the House of Veteran Affairs Committee. She has championed legislation that will strengthen our veterans' healthcare system and continues to be a valuable advocate for us in Washington today. Having worked on the front lines as a nurse, she has a deep understanding of the changes that are needed to improve the quality of healthcare available to all. Besides that, she has introduced the Veterans Care Quality Transparency Act, which would direct the GOA, the Government Accountability Office, the GAO, Government Accountability Office, to assess the effectiveness of all communication between VA and non-VA entities related to suicide prevention and mental health services. This helps to ensure that the partnerships the VA pursues with outside entities works as intended, bringing us one step closer to ending suicide in military and veteran communities. Please join me in welcoming our 2020 Health Defender, Congresswoman Ms. Lauren Underwood.
Thank you, Emily, for the warm introduction. Hi, everybody. I am so excited to join you. I'd like to start by giving my deepest thanks to Colonel Mary Lowe Mayhew and the John P. Mayhew Foundation for the award and for the work that you do to honor our nation's veterans and their families. It's an absolute honor to be recognized as your Health Defender of the Year. As a nurse and a member on the House Committee on Veterans Affairs, I have a profound appreciation for the unique challenge our veterans face, and I'm committed to improving their physical and mental well-being. Since being sworn into Congress last year, I have especially focused on improving the mental health and suicide prevention services for all veterans and improving the quality of healthcare services for our women veterans, who are the fastest growing segment of our veterans population. I've been honored to have the opportunity to work on these issues on the Veterans Affairs Committee. Working with experts in the field of suicide prevention, I've introduced a suite of evidence-based legislation to address the veteran suicide crisis. One of those bills, the Veteran Care Quality Transparency Act, has already been passed by the House, and others are moving forward. And to serve our women veterans, I've introduced legislation to improve birth control access, gender-specific care, and maternal health at the VA. I'm also so proud that my bipartisan No Coronavirus Copays for Veterans Act, which ensures that veterans are not responsible for copays for coronavirus preventive measures like an eventual vaccine, passed the House earlier this year. Our veterans have sacrificed so much for us, and it's essential that we deliver on our nation's promise to them and provide them with the best possible care. I look forward to continuing this important work with my colleagues on the committee and with organizations like the Mayhew Foundation. Thank you for your leadership and for all the work that you do on behalf of America's veterans. I hope we can be together in person soon, but until then, take good care of yourselves, everybody. Thank you.
Hello, everyone. My name is Michael Cashel. I'm the board treasurer of the John P. Mayhew Foundation, and I have the honor of introducing Colonel Mike Cannon today.
Mike is a 1980 graduate of the Duquesne University of Pittsburgh, Pennsylvania, where he was also commissioned as a second lieutenant in the U.S. Army. Mike served 30 years in the U.S. military in various assignments that took him to Nuremberg, Germany, Tacoma, Washington, Fayetteville, North Carolina, and finally, Washington, D.C. One assignment was in the Pentagon, where Mike served on September 11th, 2001. His final assignment was at the National Defense University at Fort McNair. Mike continued to serve at the National Defense University until October 2014, and as the Chief of Staff until he transitioned to private academia at the Columbia Southern Education Group. Mike began his Project 22 Pushup Challenge on August 26th, and today is his 22nd day of the challenge to help bring awareness to veteran suicides in this country and to honor those who are serving and those who continue to serve in our armed forces. He accepted the challenge from an officer he served with in the military and has handed the baton to the next Project 22 challenger so that the campaign may continue. Mike is a professional contemporary of Colonel Mary Lowe Mayhew, who extended the invitation today to participate in this symposium. Please welcome Colonel Mike Cannon.
Mike, thanks for the introduction, and I'd like to thank personally for inviting me to the Hero Symposium this morning. As Mike mentioned, Project 22 was started in 2011. It was designed to bring awareness to veteran suicide and try to prevent the 22 on average veterans that were committing suicide every day, as per a report brought out by the Department of Veterans Affairs in 2013. This project has continued. Each individual does 22 push-ups per day. This is my 22nd day. I started this journey on the 26th of August, and I have handed this over to a contemporary of mine who will continue it. We post this on social media just to keep awareness going for veteran suicide prevention. So I'm going to go ahead and do my 22 push-ups for my 22nd day, and that will conclude my portion of the ceremony. So.
Thank you. Hello, everyone. My name is Paula Huff with the John P. Mayhew Foundation. I'm pleased to be with you all today and to have the honor of introducing our 2020 Hero Defender. He represents Florida's 17th District and currently serves on the House Veterans Affairs Committee. He has prioritized veterans' needs since the first day he took office and has been a true advocate for our heroes. Having served in the Army, he has a first-hand understanding of their needs and an appreciation of what it takes to continue progress. He understands that our veterans deserve holistic care, and that means providing them with every possible effective treatment available. Besides that, he has introduced the Veterans Cannabis Use for Safe Healing Act, legislation which would prohibit the Secretary of Veterans Affairs from denying a veteran benefits due to the use of medical marijuana in states where the substance is legal. We're lucky to have him join us virtually today. Please join me in welcoming our 2020 Hero Defender, Congressman Greg Steube.
Thank you for having me today, and thank you for this incredible honor of receiving the Hero Defender Award. It is a pleasure to be with all of you, and I'm very sorry that I can't be with all of you in person. As many of us know firsthand, it's not always easy to readjust to civilian life after serving in the military. With everything else going on, access to quality and innovative health care should be the last thing veterans have to worry about. Veterans who have sacrificed for their country earned and deserve the best medical care this country can provide. That's why from the first day of my swearing in, expanding access to care for veterans has been a top priority of mine in Congress. I'm honored to announce that many of the initiatives we've worked on this Congress have either passed the House or become law. So far, we've passed H.R. 2333, the Support for Suicide Prevention Coordinators Act, into law to help better understand the responsibilities, workload, training, and vacancy rates of suicide prevention coordinators at the VA so we know what changes we need to make to best serve our nation's heroes during times of crisis. As a co-chair of the Mental Health Caucus, this was an especially important victory for us. we have passed H.R. 886, the Veteran Treatment Court Coordination Act. This law helps empower veteran treatment courts to do their jobs and get to the root of the issues in our veteran communities. For those suffering from mental illness or substance abuse issues, the veteran treatment courts provide an alternative and keep our veterans out of the criminal justice system. Both of these have become law, and we have a lot of hope that our other initiatives make it to the President's desk. So far this Congress, we have passed the Pause for Therapy Act in the House. This legislation would create a pilot program within the VA to help treat post-deployment mental health issues through service dogs. We also passed the Improving Confidence in Veterans Care Act, which would address licensure and employment requirements for medical providers at the VA to ensure that our veterans are getting top-notch care from qualified providers. One of the initiatives that I am most excited about for the future is my bill, the True Choice Act. The True Choice Bill empowers service-connected veterans and priority groups 1 through 3 with more healthcare options by providing the choice to use TRICARE Select and TRICARE for Life. This VA and DoD partnership will improve VA's ability to help veterans select the healthcare program that fits their needs. These initiatives are just the start of our work to expand access to quality healthcare for our nation's veterans. We understand that improving healthcare does not only include prescriptions and traditional medicine, it includes innovative ways to fight mental health challenges and put our heroes back on the path to success. Thank you again for this honor. I look forward to working with each of you to achieve our shared goals in the future. Thank you, and God bless.
My name is Christine Emery, and I'm delighted to be a part of the John P. Mayhew Foundation Symposium today. As you know, that this is the third annual Hero's Journey Symposium, Wounds to Wellness, and each of our panels today will focus on different pieces of that. This next panel is sort of futuristic in many ways. Long title of the New Technologies and Integrative Models of Care in Managing Mental Health and Well-Being. Don't let that put you off. This is going to be really interesting. And working with us is Dr. Beverly Gaucher, who herself is a specialist in artificial intelligence and other things that make really cool video games work well. But she won't say that that's what she does. Then we also have with us Dr. Brian Meyer and Dr. Jarrod Reisweber. Both of them will be discussing their work and a lot of their collaboration that Beverly will address. And then we will have Matt Miclette, who has worked with the veterans of Iraq and Afghanistan on a lot of the issues that we're talking about today. So without much further ado, I would like to turn this over to Beverly to facilitate our panel. Thank you.
Hello. So this is New Technologies for Integrative Models of Care for Managing Mental Health. I have a Ph.D. in statistics, and I work in artificial intelligence and machine learning. I have 9 pending patents for my predictive disease models developed at Walter Reed and the Uniformed Services University of Health Science. And I am a thorough believer for predicting disease outcome, and I'm a thorough believer that technology will be the future of medicine, will be a big part of the solution to medical problems in the future. And so I am excited to have our very impressive panel here today, starting with Dr. Brian Meyer and Dr. Reisweber, and they're going to tell us about their new integrative technologies for mental health.
So I'm Brian Meyer, and this is Dr. Reisweber, and we both work at the Central Virginia VA healthcare system in Richmond, Virginia. So we are proud Virginians, and we have worked on developing a new treatment for substance abuse that we're going to be talking about called transcending self-therapy. This is Dr. Reisweber. Do you want to add anything in your own introduction?
Just that we're excited to be here. We're going to be talking about a very new and innovative approach to treating substance abuse that we believe is going to change the landscape and going to improve a lot of healthcare outcomes for veterans and patients throughout the country and world. So buckle up, because we're excited to tell you about it, and we have a lot of ground to cover.
Okay. So we also should mention that we have a couple of co-authors who've been working with us. Kate Pollack and David Palm. Next slide, please. So we want to be clear that the things that we're going to say here are our views. They're not necessarily the views of the VA or the United States government, because those places do employ us. These are our personal views, although I don't think that there's going to be anything problematic about them. It's also important to know, in terms of conflict of interest, that we do actually have a set of manuals, which you'll hear about today, and we do receive a percentage of the profits from those manuals. Okay. Next slide, please.
So, how many of you know or love someone that was addicted to drugs such as opioids or alcohol? I'm part of that group too. This is my grandfather. He was a good man, a family man. He loved his country, but he was addicted to alcohol and likely suffered from PTSD. After flying multiple missions in World War II, many of which his plane took on fire, he returned to a country that didn't really understand him or his disorder. Juxtapose that to right now, where we have one of the best new treatments for substance abuse in the world, and it's called transcending self-therapy. If my grandfather were alive today, or if he received this therapy, I believe his life would have turned out very differently. I can't wait to talk to you today about transcending self-therapy. Before I do that, Dr. Meyer is going to talk to you about the current state of substance abuse and what we're dealing with.
Next slide, please. So this is a relatively well-known slide put out by the Centers for Disease Control. It maps out the course of overdose deaths in this country over the last 20 years, which have been rising, and especially rising steeply. There are actually 3 phases that have happened. The first phase that we've been dealing with was prescription drug overdoses. You can see those in the purple line. The second phase, when we started in 2012 and 2013 cracking down on prescriptions, what happened was that leveled off. And so people went to the street for their drugs. If they couldn't get a prescription, what they were going to do is they were hooked. And so they went to the street. And the thing that was cheapest on the street, you could get a pill, but a pill would be $5, or you could get heroin, and that would be $5 too, but it would last a lot longer than a pill. So people started getting hooked on heroin off the street, and that was the second wave of deaths, and that wave increased. And then happened, and that was the orange wave there. And then we hit the third piece. And the third piece is that then fentanyl started being introduced. It is a much more powerful opioid than either prescription medications or heroin. It's about 100 times as powerful. And because it is so powerful and it is very cheap to make in a chemical lab, that hit the street. And it's a white powder, and so it's actually indistinguishable if you put it in a pill or if you put it in heroin, which is also a white powder. It's indistinguishable. You can't tell that it's there. So a person who's taking it has no idea that they're taking fentanyl at all. And that is what caused the really steep part of the rise there. What is not represented there is other drugs and alcohol. And so I want to say a couple of things about that. We've had 72,000 overdose deaths in our country last year. That's an increase from the year before, where it was 71. And so it had actually dropped down, and now it's kicked up again. But we're not talking about the other things. This does not show you that 80,000 people died from alcohol-related causes. That's 80,000. And it doesn't show you that over this same 20-year period, the percentage of people with alcohol problems in this country rose from 8% to 12%. That's a 50% increase. It does not tell you that the fastest growing drug use in this country is neither of those. It's actually marijuana. And it doesn't tell you something which has only just come out literally in the last week, which is that for the first time ever, stimulant use, particularly methamphetamine, has been implicated in more deaths than that line that heroin shows. That's the first time that's happened in our history. And so what we're finding is this is not just an opioid problem, this is a polysubstance problem, because all of these substances are increasing. Next slide, please. So what about COVID-19? I call this the fourth wave. I was speaking with Colonel Mary Lo Mayhew before, and she said this is a tsunami. And we are in a tsunami of problems here. And so what happened in that tsunami is that people were driven indoors and separate from other people. They were socially isolated from other people who were their supports, are their supports. That increased levels of depression by 25%. That came out a week ago. It increased levels of anxiety by 30%. And we know it's caused a 13.3% increase in relapses and increases in the use of substances. So we're already seeing that. We're also already seeing, as of August, we now have data that are showing that the overdose rate in most of the most populous counties in the country have increased massively. And so what we're seeing is lots of things happening right now. So, this data basically is saying that. We've got overdoses increasing in 29 states. We've got 21 of 30 of the largest counties in the country where that's happening. And the White House even announced that we've already started seeing an 11% increase in fatalities as a result of these things. So if people want to know, is COVID-19 making these deaths of despair, the suicides and substance use problems that we have, worse? Absolutely, it is making it much worse. And those data are only for the first 4 months of this year. So that doesn't even include the heart of what we have been seeing. And so we know it's increased. It probably is worse than those data are actually saying, because those data are from earlier days in this crisis that we are facing. Next slide, please.
So when I came to this VA, there was no evidence-based open group or individual brief therapy for substance abuse. As such, we took it upon ourselves to develop a 20-session open group and a 4-session brief individual therapy for substance abuse. We developed the patient manuals and the facilitators' guides, and then we looked to see if they were working, and the data's in, and they were working at a really, really impressive rate, and we're going to talk about that later. The second problem was actually the focus of psychology. It regarded spirituality, something that 84% or more of Americans identify with, some form of religion or spirituality. It regarded spirituality as beyond the scope of 20th century psychology. Hayes captures it in the quote, "Religion had forgotten the mind, and 20th century psychology had forgotten the soul." To address this gap, we integrated cognitive behavioral therapy, which is kind of the gold standard or what a lot of people are practicing, with this simple but age-old idea. Patients are more likely to recover if they identify their morals and live life in accordance with them. To say it another way, transcending self-therapy, what we developed, emphasizes helping the patient identify their morals and become the best version of themselves. Next slide. Transcending self-therapy, or TST, is a form of integrative cognitive behavioral therapy. TST is a little unique in that it really emphasizes the moral compass or spiritual beliefs that patients have, and then tries to develop a way so that they can live in accordance with those belief systems.
That was something totally new to me. Instead of focusing everything on the 12 steps, it was on challenging your thoughts, your feelings. Are they true? Are they helpful?
So these guys, yes, they have substance abuse issues. The opioid problems that we're experiencing in this country are horrible. But we're seeing a lot of progress, and the innovations we're allowed to make here seems to be helping to address those. All we're trying to do is help them understand their thinking patterns and behavior patterns, which lead to depression and substance abuse.
I'm thinking about, in the long run, with me and my family, my fiance and my stepson. Got to be able to take care of them.
We see patients coming back and saying, this is my 10th rehab, or this is my 5th rehab. It finally clicked. Now let me tell you a little bit more about transcending self-therapy. Next slide. These are the patient manuals and facilitator guide for the 4-session individual therapy and the data. As you can see, patients who receive transcending self-therapy were twice as likely to complete treatment and twice as likely to be abstinent in the final week of treatment. Further, they saw significant improvements in their depression scores and were significantly less likely to need additional or a higher level of care after treatment. So depression went down when compared to treatment as usual, and they were significantly less likely to have to go to a higher level of care because of transcending self-therapy. Now this has access and financial ramifications. For instance, one estimate was that when extrapolated across the year, it saved the Richmond VA over $500,000 in that year. Next slide.
So transcending self-therapy is based on what we call a biopsychosocial spiritual model. Now, traditional care and integrative care has been based on the biopsychosocial model for the last 40 or so years. What we have added is the spiritual portion of it. And we talk about how clients have to seek meaning in their lives and transcend. And when we speak of transcending, what we mean is looking beyond the self. One of the things that happens when people have substance use problems is they become drug seeking, and therefore they become very self-centered because it's all about them and their relationship to the drug, and often other relationships are left behind or they're just plain old destroyed. And this what we have them do is we have them develop what we call a passionate pursuit that is in line with their moral compass. So we're focusing on what their values are, and then we have them develop something that they can commit themselves to that is beyond themselves, and that is how they transcend themselves. And what you can see is that from the data we have, that when people actually started living life in accord with their morals and values, you know, maybe they wanted to be more involved in their son's life. Okay, then they got more involved in their son's life. That was something beyond them, beyond themselves, and they were reaching out to somebody else. Some people wanted to learn to reach out to how to help other people or to volunteer in different causes, or it didn't matter what it was, as long as it was something in line, they had that passionate pursuit, lifted themselves out of being focused on the drug and onto other causes that fit with their morality and values.
Next slide. And so, basically, when we explain what we did, a lot of people are like, well, duh, why didn't you figure out that earlier? Is we combined symptom reduction with when a patient comes into rehab and is at a low point in their life. We're not just saying stop doing drugs. What we're saying is, who is that person you want to be? They then decide that, they reflect on their morals, sometimes it's their spirituality, and you say, this is who I want to be. I know I'm better than this. And we say, we know you are too. How do we get you there? How do we work with you towards that? And so it's a philosophical change. Some people regard it for themselves as a spiritual change. TST makes no ontological claims about the legitimacy of any religion, but we do support the patient identifying what is deep and meaningful to them, and then how do they go and get that. So here you'll see the patient manual and facilitator guide for the 20-session open group therapy, as well as the data. And what you'll see is patients who received transcending self-therapy were significantly less likely to use while in treatment, and they were significantly, let me say this correctly, they were over 2 times less likely to have a positive urine drug screen when they came back from treatment in the month after. Let me say that again. Patients who received transcending self-therapy had were 2 times less likely to have a positive urine drug screen in the month after treatment. Next slide.
So what are we trying to do with this? How do we get this out into the world? And that's a really critical question. You can have something really great. And I think that what we have here is an answer to the problem that I was talking about before. We have had good treatments. But with the rise in our opioid deaths, with the rise in the use of stimulants and marijuana and alcohol, and the increasing deaths of despair that we are seeing, our treatments have not been good enough. This is about having a good enough treatment. And so what we're seeing is when we're comparing it to treatment as usual, this is a better treatment. And we believe that if we distribute this outwards, that then we're going to be able to make a situation where a lot more people are going to get help and be able to stop their using. So what we did is we received some grant funding to pilot this across the country. And so what our preliminary data from these other pilot sites shows, so what we did is we went out and we trained them. And what we have found basically is the following. Yes, they're less likely to use drugs and alcohol compared to the kind of treatment that they were getting before. That they, when they looked at their own quality of life scores, and that's really important. That's where this psychosocial spiritual portion of it comes in, your quality of life. And they rated their quality of life as better. When we talked to the people, the clinicians who were actually providing this treatment, and asked them to compare it to how well they liked this treatment and providing it versus other ones, the clinicians liked providing this one better. And so there has been this kind of organic spread of transcending self-therapy in the VA. And on average, what we have found is that there's about $250,000 savings per hospital as we have spread it out there. So it's not quite as much as the original data showed, but we are still seeing massive cost savings on top of the life savings. We're saving lives and we're saving money at the same time. Next slide, please. So where are we going with this? We have a lot of next steps. Sometimes it feels like wildfire. Sometimes it feels like you're holding up the world because there's so much that's going on. So you've heard about it going into some other VAs around the country. Yes, it is going international. There is, starting next month, Dr. Reisweber is going to be going out and doing training in, whoops, remind me of the country.
Europe, but
Europe is the country. No. Somewhere in Europe. And
come back to me on that one.
Sorry about that. Put you on the spot. Training, but I mean, we're taking it outside of the United States.
Slovakia.
Slovakia.
If we can edit that out, that'd be great.
We have a massive expansion grant, $1.25 million grant that we're doing, and we are training 65 clinicians at Virginia Commonwealth University. And as those people go out and spread, they will spread to other people as well. We've been publishing a lot. We just had an article on the group therapy come out. We had earlier, the article on individual TST. We are literally, I got in my email last night, what is close to the final draft of the next article, which is a case sample. And then we're going to be putting out this data on the pilot sites that you just saw some of. We also have been named in a book that is going to be published by Oxford University Press very soon. I don't know exactly. I mean, it's supposed to be weeks around now. Yeah. Which is naming transcending self-therapy as one of the best new treatments for substance use in the world, which is pretty good from Oxford University Press. We have received 3 innovation grants. We've received 2 grants that are from the Mental Illness Research and Education Centers of the VA. We do have a website, transcendingselftherapy.com, and so there is a way that other people can get a hold of it. The way we have built this is that we talk in the manuals about how to do the treatment. So yes, we train people to do it, but the truth is that people can buy the manuals and actually do it themselves as long as they know something about cognitive behavioral therapy coming into it. And from a technology point of view, we are now partnering with a virtual reality company, which is now going to turn this into 20 lessons with multiple levels on each lesson that they can use so people can engage and learn in a different kind of way, because not everybody gets it in sort of the psychotherapy way. They have to learn in other ways. And so we're going to have this in virtual reality form. This has been a very explosive growth for something that is really in its final form, 2 years old now?
2 or 3, yeah.
2 or 3 years.
Happened quick.
All of this has happened very, very fast. So next slides, please.
And I think part of that too is, yes, please, next slide, is that it's not just stop using. It's not symptom reduction. It is, who is that person? If you've known substance abuse or if you've known addiction, you realize that it can be a philosophical or a spiritual addiction. And if you can find that good person that everyone can be and live life in accordance with that, it makes sense that we're getting this kind of data. So it's kind of a different approach that's using some of the good old-fashioned CBT that we know that works. So what do we need is we need champions. If you're listening to this, if you're sitting here in the crowd and you are interested in it, to try and champion us, you can see transcendingselftherapy.com. Feel free to screenshot that or whatever. That's where you can go to get all the information about it. Financial resources are always appreciated. And we need venues. So we're still looking at places that we can roll this out because we believe that it's a very effective therapy. You can, of course, email me right here at my VCU email. Also can be contacted at the VA, but the transcendingselftherapy.com has a ton more information on it, and I would like for you to go there. Next slide, please. So I'm going to end with a story that's woven throughout our manuals and very consistent with our idea that we are trying to facilitate patients becoming the best versions of themselves. I'm actually going to read from one of the manuals that we wrote. And I invite you to look along on the screen. A grandfather was teaching his son about life. A fight is going on inside me, he said to the boy. It's a terrible fight between two wolves. One is dark and evil. He is anger, jealousy, sorrow, regret, greed, arrogance, self-pity, guilt, resentment, inferiority, lies, false pride, superiority, and ego. He continued, the other is light and good. He is joy, peace, love, hope, serenity, humility, kindness, benevolence, empathy, generosity, truth, compassion, and faith. The same fight is going on inside you and inside of every other person too, he said. The grandson thought about it for a minute and then asked, Grandfather, which wolf wins? The grandfather quietly replied, the one you feed. Now, I know my grandfather's looking down right now and is happy and proud that people are getting this message and people are getting this treatment. We hope very much that many more people can get this treatment and that our continued efforts can be supportive. We ask for your help, and thank you. Thank you.
That's quite brilliant. But how, I'm particularly interested in the virtual reality. That sounds quite fascinating. But how did this therapy develop? Where did it come from?
So that's a good question. It came from, I think, years of addiction treatment for Dr. Meyer and I, and realizing that just saying stop using isn't good enough, and getting them to say stop your stinking thinking isn't good enough. And we found that if patients find that best version of themselves, if they're religious or spiritual, if they identify with that religion and they become closer to that and embody that, and they do good. The motto for our therapy is following your passion with compassion. So the idea is to follow your passion. Some people say follow your calling, and then have compassion for both yourself and others. And then mechanistically, we were working in the VA, and the VA right now is one of the most innovative and great places to work, and I truly mean that. At the Richmond VA, we have just outstanding leadership, and then nationally through, we have what's called the Innovation Network. And what it does is it says, there's a call every year in the VA for good ideas. You submit your good ideas, and then they go up the ladder and are kind of filtered through, and then they sponsor. I think they sponsored us again this year. 93 different groups were sponsored. So the VA is really a place where now we're not just a treatment center. We're not just the biggest treatment facility in the world. Now we're really trying to push the bounds and become the best treatment providers in the world. So the VA is advancing it, and then we were able to do a collaboration with Virginia Commonwealth University and private sector to really kind of pull from the expertise of different areas. So the old idea about the VA is not anymore. Now it's an innovative place that's really trying to push care in a positive level. Thank you.
Thank you very much. Our next speaker is Matt Miclette. He is the Director of Clinical Operation at Neuroflow, and he is as well a veteran. And we are looking forward to hearing what you have to say about technology.
Great. I'm looking forward to speaking about it, so glad we're on the same page. Good morning, everybody. I'm really happy to be here. Thank you for the Mayhew Foundation for the invite today. It's also nice to see people, which has really changed my day quite a bit. So thank you all again. I'm here to talk a little bit about digital health, and I think there's a bunch of different approaches that people have been taking to how to use digital health to address mental health and substance use problems. But here really today to kind of talk a little bit about our approach and why we hope that other companies take our lead, and also that we can continue through the studies that we've been doing to show value in our methods. So if you wouldn't mind starting with the first slide. And I always like to start off by talking about the separation that exists between physical health and mental health, right? For so long, we've been, ever since pretty much we've started to fund healthcare, we've been funding mental health quite differently than we have with physical health conditions, right? So even to this day, if you have a private insurer, they probably have something called a carve-out, where it's not even your insurance company that's paying for things, right? It's this separate third party that's actually paying anytime you see a mental health provider, and that runs pervasive throughout the healthcare system. So if you go see your primary care provider, they're going to treat things like your diabetes and hypertension, but they're going to refer you, right, when it comes to treating your mental health conditions, because they feel uncomfortable. They don't know what to do, right? And I can tell you, as somebody who treated combat injuries, at Walter Reed, and the praise and admiration that we got doing that job, and going home and feeling like you have a sense of purpose because people tell you so, and then going to treat individuals at an inpatient psych unit where you feel that stigma, right? It exists, it's real. It's as much as we are fighting it with events like this today, to say we've done the job would be insincere. And working on the unit, there was a lot of times where you see people coming in and you can't help but think there's no reason this person should have been here. We should have caught this way upstream. There were so many points and opportunities to intervene. And that's what I think is so interesting when I talk about mental health is to think about other chronic health conditions, right, as our baseline here. And when we think about things like hypertension and diabetes, how do we manage and treat those conditions, right? Well, we do a few things. We're doing routine measurement, right? We're doing our finger sticks to check our blood sugar every maybe 3 times a day, right? Maybe before meals, before bed. And then, hypertension, we even have the machines inside your CVS, right, to go get some routine checks. And being advised by our doctors to do these routine checks. But with mental health, we're not doing that. You're probably getting your one screening every year at your provider. I'm sure you guys are all very familiar with the PHQ, and let's be frank, it's in with all of our other insurance docs and everything else, right? So who's not racing through to finish that? If you're like me, you're always late for your doctor's appointment anyway. And the treatments also look very similar. right? What are we asking for people with diabetes and hypertension? Well, we're asking for some sort of behavior change, right? Something in your life isn't working and conducive to your physical health. We need to make changes. We need you to walk more. We need you to exercise more. We need you to eat more healthy. The same is very true of mental health conditions, right? Things need to change. How we're living our lives is not supportive to the way you want it to be. So maybe that means more socializing, right? If you have depression, it might be going out and being with friends, right? How do you create that behavioral activation, which we commonly refer to in CBT, right? How do we get that to happen? But it's really similar to diabetes and hypertension. Medications, right? How do we keep people to take their medications every day? We know that there are medications that work. You know, substance use disorder, there are medications that work and are very effective. Yet we put restrictions on them, right? So going back to these walls, right? Things like buprenorphine, you have to get a waiver for to treat substance use conditions. So again, the split is just so apparent, and every day we see it, yet the treatments and management of these conditions really should be quite similar. And that's sort of our approach. So if you go to the next slide, really our goal is to really do three main things at Neuroflow. The first is measurement, right? So how do we create this routine measurement like we would with somebody with diabetes and checking their blood sugars? So we do that a couple different ways. The first is the very traditional validated screening tools, right? So things like a GAD, PHQ, PCL for PTSD, right? There's a number, and it depends on the condition. So it's not like we're gonna just throw everything at the wall, right? It's very dependent. We can also look at things like mood and sleep and subjective measures, because that's what makes mental health really challenging, is now we also need to pull in, how are you feeling, right? And those daily ups and downs that we have, how do we actually account for those? And then third is also more passive intake of information. So you can think about steps and activity data. So somebody with, I'm going to go to cocaine use disorder just because of my friends next to me here, you know, if you see a huge jump in their activity and steps, right, for a couple of days, we could probably start to infer a few things, right? Same with someone with bipolar disorder or depression, maybe the opposite, right? So being able to collect more of this passive data, especially from wearables and watches. And while that's all great, we also know that providers are very limited on time. So we're not here to overload them with data, right? So if we can take all that and collect it and put it in a way where we can really calculate a single metric of risk, right? And a cumulative risk score is really what we're doing in a way where now you have a metric where you can compare this individual over a population. So where in my Philadelphia VA does this patient fall, right? And when I come in and I'm the care manager or case manager for that clinic, I know who do I need to get in touch with and call today, this morning. And who are some people that really need to be on my radar because they're trending in the wrong direction. They had a drop from one month to the next. And then even one step further is how do we help primary care providers? Because they've been uncomfortable for so long treating mental health conditions that if we can gain these insights and understand their treatment algorithms even based on their organization, then we can give them exactly what they should be doing based on clinical recommendations, right? If we know that they've been on an SSRI for 4 to 6 weeks and we haven't seen effect, maybe it's time for a change, right? Maybe it's time for referral to therapy based on their trends of their different scores. And then the third thing that really matters the most here, and I think this is why we've been the most effective at this, is how do you actually engage patients? We know that there are effective treatments that work. TST clearly is one of those, right? But if people aren't going home and doing their homework, and they're not doing their work outside of the clinic, or we're not engaging them with some preventative resources beforehand, then we're not going to see results that we're looking for. So we really need an engaging way to keep people want to actually, part of my language, this is a veteran military thing, so we need them to give a shit, right? That's what it comes down to. So how do we create that sense of ownership? So if you go to the next slide, so you know, one component of this is having a mobile app, right? We do have web-based dashboard as well. I didn't know there was animation, so you feel free to click through a couple times. And there's a few things that we do, right? A lot of behavioral economics built in, and that's the idea here, is how do you use what is evidence-based to get people to engage? So that could include things like financial incentives, right? We know that there's a lot of research to support. Even if you give a small amount of money to somebody, they're way more likely to engage and actually do those treatments. So we have small gift cards, things like that for Amazon, Target, that sort of thing, where no, you're not going to retire, but it's certainly enough to see that increases in engagement we're looking for. We also do things like nudging and making sure that, hey, this person knows it's time to do their homework. I got into a bike accident. I always have to clarify a mountain bike. I can't say like a badass motorcycle man. But, you know, and I had this great app for the PT I was getting, which showed me how to do all the exercises, and I was really, really impressed, but it never actually nudged me to do it. So despite having that resource, I still never actually completed my exercise every day, right? And again, and making it, and the design was done by by people who have actually worked in the consumer world. So, myself, I have asked my patients to use the VA apps quite a bit, right? So CPT and the PTSD coach, right? All these great apps that do exist for sleep and insomnia and smoking and the like. The challenge was always that there's 16 different apps, right? So there's no one source of truth, and that they never also tied back to the provider. So that's kind of the second piece that we're working on. If we just go to the next slide, is also being able to feed all of that information back to a provider dashboard. And really there's two ways that this works. One is if I'm the individual clinician and being able to track my own metrics of my patients over time, practice measurement-based care, right? Like I would as someone treating diabetes. And also being able to then do some population health insights, right? So how do we actually inform the enterprise about what's going on? So some of our work with the Air Force, we're actually feeding that information up from individual units to know which unit actually needs resources allocated to them. Which units are most at risk right now and will need some help with maybe some additional training. Maybe they need a day off, right? But at least we know that that's who needs the intervention. All right, yeah, you can go to the next slide. I forgot what order these are in, so this will be a mystery for me too. Great, great, story time. So just real quick example of kind of what this looks like in practice, right, is, this very well could be a Philadelphia firefighter. That's one group we work with, first responders, is a population health rollout. So we actually rolled out this application to a population, right, and give them different resilience and type activities, and based on their outcomes of their various, whether it's screenings we do or their mood and sleep tracking, we can actually then target the resources and curriculums that best suited for that individual. So if I'm coming up as somebody who's very anxious, if you haven't picked that up, I'm doing great, then I'm gonna get stuff much more geared toward anxiety. Whereas Mary Lowe, who's very well-adjusted individual, right, might get more stuff around positive psychology, right? And also able to then target things like loneliness and isolation and those social determinants, and we've been talking a lot about diseases of despair today, then we can actually send those very unique resources to the individual. So we're not throwing the kitchen sink, but able to tailor that approach based on the need of that individual. So you can see, as Sam's gone through here, he did his annual screening or PHA in the military very early on in the year, and he was fine. At that moment, things were great, or maybe he raced through to fill it out. But things got worse. He just got diagnosed with chronic health conditions. First time he's really had health problems at 47, right? Marriage problems. We all have relationship difficulties here and there. And with all of these blue points are opportunities where we really could have intervened, right? We can pick up on the fact that he's doing these terrible mood ratings. We can pick up on the fact that he's feeling lonely. We can pick up on the fact that he's is now above that clinical threshold for depression. And with that, we can assign either get him resources, show him how to actually access those resources himself, or reach out through care coordinators or others to actually get him into that care directly. And that's something that my team does as well, is then do those warm handoffs directly to an EAP or some, in the Air Force use case, over to the mental health flight themselves. I think I have one more slide, outcomes, which is always important. And the last point I'll really make is we're not a digital therapeutic, right? We're not here to say, hey, Neuroflow is making these changes and that's why we're seeing awesome results, because it's not. Why we're seeing cool results, what you can see on the screen here is in terms of engagement and outcomes, is largely because we're informing providers of how patients are doing, how to reach out to them sooner, and some sort of at least idea of what they can do with those patients. So seeing a drop in patients that were from severe anxiety to moderate of 73% is no small task, right? And that's really a result of empowering providers with this knowledge and not overburdening them with data. And that's really our goal and what we're trying to do at Neuroflow. I think the last point I'll make is also understanding, again, that being engaging is really the name of the game here. And I think that's where a lot of digital health has failed in the past. And we're not reinventing the wheel with a lot of the measurement pieces we're doing. We're not reinventing the wheel with some of the curriculum that we developed, right? These are all based on previous work of awesome researchers, right? But being able to put it in a package in a way where we're tailoring things and not throwing the kitchen sink, and also in a way where people come back month over month and continue to complete these activities, that's where we're going to be able to catch them upstream, do these prevention activities, and then also get people on the road to wellness and to the proper level of care, which I think is something we should always be thinking about is treatment capacity. Next, I'll leave it there.
That is fascinating work you're doing at Neuroflow. What are some of the populations you're working with?
Sure. Yeah, it's fascinating because originally we started working with behavioral health specialists, and that was our niche. So it was really just a tool to assign homework, right? Hey, you can put in whatever homework assignments you want, which is still true today, right? So I'm not telling you how to do your work. You can trust Matt, but you have your own practice, your own way you want to deliver care. So it was a way to deliver homework and practice measurement-based care. And then when collaborative care codes came out in 2018, that's when we saw there was a real opportunity to support the physical health. So that's when we started to work with physical health clinics. We have a large chronic pain population that we work with, where we're now helping them to do collaborative care in this behavioral health integration. And now also have now pivoted into population health, where now we're working with health payers. We mentioned some of our first responder use cases, the military, so we're with both U.S. Space Force and Air Mobility Command and the Air Force. We worked with Philadelphia VA through a National Science Foundation grant, and then we're also now working with a few other VA medical centers as well to, again, because we're flexible and able to work with different use cases, really been able to support a bunch of different organizations with what we do.
So what problems does Neuroflow address exactly in these populations?
Sure, yeah. Well, what we were really trying to solve for is treatment capacity, right? We know that there simply isn't enough providers out there to treat the number of people that genuinely need care. And we also know that 2/3 of the people with a mental health disorder will never actually get the care that they need. So what we're trying to do is figure out what is the lowest level of care to be effective for an individual, which is a lot of, hey, we don't need to be referring every single person to a psychiatrist or every single person to a psychologist. What is the proper level of care for each individual patient to get them using stepped care model, right? And then also, how do we prevent things upstream, whether it's getting them resources, so we talked again, social determinants and things like that. So both to slow by preventing people from needing care in the first place, by getting them resources earlier, and also getting people to the proper level of care, and supporting the models like collaborative care model, where now we can really help bring that to the primary care clinic to more effectively treat patients and only take, it takes roughly 5 minutes of a psychiatrist's time per that patient. Instead of these large sessions, now we can see patients in the hundreds, whereas before it was quite limited.
I see. And so how is it that you'll be measuring success in the future?
Yeah, that's a great question. I think the luxury of being digital health and very data driven is we collect a lot of the metrics themselves, right? So we are able to gather, certainly, we know that the validated assessments are always a great measurement tool and in yardstick. But I also think it's going to be engagement is really where we're going to have to keep our eye on, and that we're really focused on, because we have the flexibility of delivering anything, right? Any sort of content that supports the models that are being done at different medical centers. Then if we can get people to engage with that, then that's really what matters. So we actually will look at activities based on different curriculums and see what is being most engaged with, and bring it back to that organization and say, hey, look, we know that this journal is really important, but people are not engaging with it. What else can we do? So maybe we'll change the point value, right? So that's worth more points. Or maybe we'll replace it with a different type of activity. But really looking at an iterative approach where how do we continue to get people to engage with these activities that we know work, but if they're not using it, then we're not going to see the outcomes. So I would say engagement's absolutely a metric we're going to keep in mind for the long term. And we do have a couple papers under review now in terms of some of the outcomes that we showed earlier.
And what populations are you hoping to expand into?
Yeah, that's a great question. Military has always been something that my team's been passionate about. We have a number of veterans, on our team, and our founding story is essentially that, we had a soldier who came back from deployment. He went through the screenings, post-deployment screenings, and was positive for depression. He got referred, right, which is great. That's the success story. And it was actually at Fort Hood, where I was as well, around the same time. And he got referred to the Resiliency Center, but he never showed up. He got prescribed a medication, never filled it, and quite frankly, he fell through the cracks, right? And the idea here that there was no follow-up with that soldier has really been the drive for us. And knowing that if we have some sort of way to track and look at people over time and see their outcomes and being able to reach out to him that moment of crisis, then maybe we could have saved a life, right? We don't know if we could have saved his life, but certainly hope that in the future we can save others. And first responders, military have all been great, but really population health and just trying to figure out how do we make sure people get resources that are tailored to them, to their geography, is really what our drive is.
That's quite brilliant. I was wondering about your virtual, the development of what is your plan for the development of the virtual side of your
Yeah, that's
therapy?
a good question. So we were fortunate enough to get funding from Virginia Commonwealth University and the Richmond VA through the Innovation Network. And we're working with some folks to develop basically a virtual platform. So exactly as you were saying, we want to make homework that they want to do. Homework is one of the better predictors of treatment success. It's kind of like that idea if you went to a tennis coach and he showed you how to swing a racket from the very first session, and then you don't practice between sessions, you're not nearly as likely to get better than if you would practice for 10 hours between sessions. So we see that with our TST. And so what we're trying to do is a virtual platform. So it's basically right now the funding that we have.
Total around $300,000 in the last 2 months to do the preliminary kind of kickstart is
full 3D goggles, 4 sessions, and then each session is the homework between the individual therapy sessions, and they advance in complexity. The long-term goal is for, as you were saying, how the patient does on those sessions, where they do well, where they do poorly. That data then gets put into something that's useful for the provider, so the provider could say, oh gosh, he or she's struggling understanding thoughts versus feelings, or he or she's can identify his or her thoughts.
They can't challenge her, or he or she didn't do it. So it gives us good data. So that's the stage. I think the
VA is really trying to do a good job of responding to the crisis by providing alternate mediums for telehealth so that we can meet patients in their homes. So this is one of the many programs. But in short, it's the preliminary program, 4 sessions, the homework, that each day they
do it in advanced complexity. And we're trying to make something that they want to do and that's useful. So that's where we're at. The end goal at some point is to create
the virtual ability to provide care where somebody in Appalachia, somebody in Norfolk, and somebody in Richmond can meet in a group and we can do care together. But that's still a ways down the road.
Well, thank you. Well, thank you to all our panelists. It's I think it's time. So, okay. I do have one more question. How do you overcome state medical laws?
For instance, I know with the VA, you get to do it federal, so you can shoot, you can treat something wrong. How do you, are you working with the VA to do your virtual medicine? I mean, are you working with the federal health system to do the virtual medicine? Or?
Well, we work for the VA.
Oh, that's right.
So we consult. It's actually, they do a really good job of providing us with the consultants same day so that they can continue to advance the care that we're doing. So it goes along with what I was saying earlier in that it does seem that we're able to push things forward, because if you do have a question like that, I'm a psychologist, not a lawyer, I don't know those things. I can call an innovation specialist like Suzanne Shirley or Kate Beckner, and they, within hours, have me on the phone with tech transfer specialist or somebody from legal to be like, oh, here's what you need to know, here's what you need to be mindful of, here's the files. So it's fascinating how agile the VA is becoming. So working within the VA, it's a process, but it's one that they now have kind of streamlined through the innovation.
I would just add to that, all people who are doing behavioral health had to pivot to telemedicine very, very quickly. Aside from some technological bumps at the very beginning, which had to do with capacity, trying to jump the capacity, which is the same thing we see at the start of schools, people not getting on. It's been a relatively smooth transition. And one of the things that happened that I think is really critical is that the federal government, under emergency powers, suspended a lot of the between state stuff. And so people can now do telemedicine, telehealth, telemental health across state lines. And we can do this, we do PTSD, and we can have people theoretically in multiple states where we could do it, although we are responsible, obviously, for our catchment areas, so that's where we're starting. But for example, we have 3 different what are called community-based outpatient clinics, and we're developing 2 more of them in the next year. And we could have people literally from all over Central Virginia all be participating in the same group just by doing it that way. And the hope ultimately is, and there's been, I know, a lot of discussion of it, to turn what have been certain emergency authorizations into legislation and make this permanent. I mean, I am licensed in the state of Virginia, and I can work in any VA in the country because it's federal. But, you know, if I have a patient who's coming to me, say, from North Carolina, if I don't have a license in North Carolina and I'm not a VA provider, I can't do it. I can't cross the state line because North Carolina has a law that says you have to be licensed in North Carolina in order to do that. And unfortunately, there are 50 states with 50 laws. All of that has been suspended. And so if we turn it into federal legislation and make that permanent, that people can, if they are licensed in one state, do telemental health in another state, I think that we're going to see enormous advances.
That's fascinating. So eventually you go from just the federal, the VA system to the private system. I was not aware that they existed. Yeah, because I think in the time of telehealth and virtual reality and so on, our communication is so much closer in the world than we ever were. You know? So I think that
we're both closer and farther. That's the fascinating thing about it. I mean, I know that most of my patients, I have a couple of patients who really like telehealth better. Of course, they have post-traumatic stress and they like to be isolated and they don't want to be around other people, so they really like it better. Or we have people who don't like the parking problem, so they don't want to do that, so they like it better. But also, the majority of them, the grand majority of them, really say, bug me every week and say, when am I going to get to see you face to face? There's something about that personal connection, the feel of it, that people feel like it's missing. And so, and that's the stuff about the isolation, the separation, and that's what's driving all of those increases that I talked about in mental health problems. It's driving all of them.
The novelty of mental health, for sure, right?
Yes, it does.
Beverly, we have a question from the audience.
oh yes, please.
Please walk up and ask the question.
Walk up?
Yeah, please walk up to where we can hear you. I know your voice carries. So.
Let's hope so.
You go to the podium, sir, if you wish.
My question is for anyone on the panel to address, that if you didn't say too much about it all, but how do you guys address or diffuse resistance to treatment? Very, very common issue we all deal with from time to time, and someone has been identified. I'm all ears.
I'm happy to take a stab.
We can all take a stab.
Yeah. This is a great question. This is my favorite question because military populations, first responders, right?
Yeah, yeah.
Like, you've got to twist their arm a lot of times. And the truth is, it's messaging, and that's been a huge, huge component for us. So when we talk about what the first thing they're going to do on a digital application, right, it's going to be having to see someone that they know and respect, talking about why this matters, and really a big thing is about performance. Like what matters to them as a military service member, as a first responder, is conditioning and performance at their job. So if you talk about this in terms of performance psychology, and how this is about making you a better firefighter, this is about making you a better father, this is about making it about other people and their purpose, then that to me has certainly driven a lot of the engagement that we've been looking for. On top of a little subtle education, right, in there that, hey, this stuff works if you want it to. So a little bit of psychoeducation thrown in there to kind of break down those walls, right? So that when they do finally come to see psychologists and the like, they kind of know what to expect, and that helps them break down those walls.
Yeah, I think you hit the nail on the head. And that's what we were talking about before, is it's not doing treatment to the patient, it's doing treatment with the patient. And so there's a couple things. What you touched on, I'll piggyback on that, in that we try and figure out what does the patient want. If we force our objective or our agenda on the patient, they're not going to be on board. But if we can get to, there is something very, very powerful in each human being, and that a lot of times is their spirituality or their moral compass or their morality, but something in them that they're passionate about doing. If we can remind them of that, especially when they're in their addiction. When they come to you to rehab, that's usually when they're in one of the worst places of their life. And if we can say, we're not just going to take away the drug, we're going to figure out what is that best version of you. And then they say it, maybe even a little shyly, and I say, you can do that. And if we support them, you not only stop the person from using drugs, but then you put them back into society as a compassionate, loving member. And if you believe in religion, that's following their calling. If you don't believe in religion, that's following their moral compass. So I think this is something that helps not only the patient, but humanity. The other thing, and I'm going to leave time for Brian, is that it's clinical grist for the mill. And what I mean with that is when a patient comes in and he or she is resistant, I try and understand what is it that's stopping this patient from wanting to share it. So sometimes I may say something like, gosh, what about this office makes it hard for people to talk? That invites them in to be a little freer to talk about, like, well, it's really cold in here, or you have a 3-piece suit on, it's freaking me out. Whatever it is, you can start to understand, all right, this is their psyche, this is how they think, and then say, thank you so much for sharing that. And so it helps you understand what the patient's bringing to the room, but it also helps you understand what is the cause of the resistance. Because the resistance could be something from, I'm scared, I don't know that you're going to get me, I don't know that you're going to judge me, I don't know that you're going to look down at me, I don't know that you're going to hurt me. And so if you can address those, get them to share that with you, encourage them, and show them that this is in the context of unconditional positive regard, meaning I care about you very deeply no matter what you say, and anything you say in here is okay, and I'm here for you. That usually can be very helpful.
So just to add on to all of that, I think first contact is critical. And whether the first contact is on the phone, whether the first contact is you're meeting them in the waiting room, or the first contact is you're waiting for them in a group. And the job of first contact, I believe, is to say two things. One is I get it, and the other is there's hope. So for example, when I go see somebody who is waiting for me in the waiting room, the first thing I do is I introduce myself and I ask them, how are they doing? And 90% of the people say something to the effect of, okay, or fine. 90% of them will say one of those two things. The others will say, I'm miserable. Nobody says I'm happy, because nobody comes to therapy happy. I mean, you wouldn't need to. You wouldn't need therapy if you were happy. So, and to those 90%, let's say they say it's okay. I say to them, so when you say okay, do you mean that's a good okay? You're really doing fine? Do you mean that's a bad okay because it's like you feel terrible? Or are you just saying okay to blow me off? And I've just taken away a whole lot of resistance because I've given them 3 different possibilities that they can choose from among. And it's always one of those 3. It's rarely that it's a good okay. It's mostly either a bad okay that they really didn't want to admit to this stranger, or they're just blowing me off. And I say, great. And so what I've said to them is a critical message, which is, I'm going to listen to you. I'm not necessarily going to take you at face value. I'm going to really listen for what's underneath.
And then I'm going to start to work with you on it literally on the walk to my office. Lots of therapists say, no, we can't talk in the hallways. I'm working with people on the walk to my office. I'm not getting anything deep out of them. I'm establishing a relationship. And this was really brought home to me by a Vietnam veteran who I met probably 9 years ago. And he was in a wheelchair because of crippling injuries he'd suffered in an accident. He was extremely severe. Okay, he had terrible PTSD from Vietnam. And on top of that, he had PTSD from the accident. And he had developed a psychosis around it such that when he experienced a flashback, it was so real to him that he started shooting up his house in his neighborhood. So of course the cops came, SWAT team, you know, and they threw him in jail, which was not helpful to him. And he ended up having a complete psychotic break there. And then they realized, oh, and so they sent him to the psych hospital, and the psych hospital released him, and then he showed up in my office. It's like, oh, good. He's got an alcohol problem, he's got physical problems, he's got psychological problems. What do I do with him? And the real answer is, what am I doing with him in the hallway? And so we walked down the hallway, and we had a little conversation that went kind of like that. And we got to my door, and by the way, I always walk in front of a veteran, never walk on their side or behind their back, because then they're totally suspicious of you. They need to see you. Always go to the door, don't let them in first. That's a crazy idea for a veteran, because who knows what's in there? And if they've got post-traumatic stress, there might be danger in there. I just have to walk into my office first. Nobody taught me this, okay? You have to learn that really fast. And so, you know, I'm walking a step and a half in front of this guy all the way, and we're talking along the way, and I'm looking back at him, but he can see me, he can see where my hands are, because that's really critical. They really worry about what you've got in your hands. And then I walk in front of him to make sure I go to the door first, and I put my hand on the knob, and the veteran says, wait a moment. I said, okay, what is it? And he says, you know that if I didn't like you, I wouldn't go in that office. And I said, yes, I know that. What would you like to do? He said, go in the office. And that's how you do it. I swear to you, that is how you do it. You have to be culturally sensitive to these folks. You have to talk with them. You can't take them just at face value. And you can use some chit-chat to really actually start developing something. So that by the time you hit your office, then you can start talking about the more serious stuff. So that was a long answer to your question, but yes, that's the way I think you start.
Yeah, thank you.
I would add to that one thing too, from a transcending self-therapy perspective, the way Dr. Meyer and I treat and teach our trainees is we never want to hear a trainee or a provider in the VA say, he just wasn't ready for treatment. We have the idea that it's not if they get better, it's how they get better. So our job from day one to when they leave treatment is to be constantly racking our brain for what can we do now, what can we do now, what can we not do now. And we also, TST advocates for this, that we are willing to work harder than our patient. So those are key points too. There's never a trainee or a provider that's allowed to say they weren't ready. Because no, then we just need to go back to the drawing board and figure out what we need to do to kind of work around that resistance or work with that resistance.
And all of that touches on a whole thing that we all do now in therapy and in medicine called motivational interviewing. And with motivational interviewing, there are multiple stages that somebody goes through in terms of are they actually going to work with you. And most people in substance use problems come in what's called pre-contemplation. In other words, they're not even thinking about dropping their substance, but maybe the court sent them there, or their partner or spouse sent them there. One or the other. 90% of people come in for one of those two reasons. They're not motivated to change, but they are motivated by something external, which is telling them to change. And so that gives you a little bit of a hook. And so you try to move people by using certain motivational interviewing techniques to move from not thinking about it to just beginning to think about it. just a little bit, you know, and you move them along to contemplation, to planning for a change, and then to implementing a change, and then to see where the implementation is not working very well is what you call measurement-based care, and you're constantly actually doing measurement in that kind of way, and they're going back and forth. I mean, nobody just suddenly quits substances. I mean, addiction is a very, very powerful thing. And so you're working with them as they back and forth, and the idea is to get them into an upward spiral of recovery. That's really what you're trying to do. And transcending self-therapy, I think, really
moves people in that direction, because every success allows the potential for the next success to happen.
Well, thank you very much. I think it's been a wonderful panel. Your response to the last story about your veteran was an incredible answer. I hope that he answered your question. I would hope the best for you with your in the future with your endeavors, and I'd like to thank you again for being a part of this panel.
Thanks.
Thank you. Thank you for having us.